Secretary, the course director, immediate past president of Indian College of Cardiology, and head of the Department of Cardiology, SDPJ Lucknow, the man in the limelight, Dr. PK Goel, CTO basic principles of the wire handling. But the time allotted is fixed for him also.
Yeah. Okay, thank you and welcome everyone here to Lucknow. So what I'm going to tell you will be a little different. It's the basic principles of wire handling. You know, you listen to everyone tells you about the product and this and that. Actually, what happens is, why is it not changing? Why is it not changing? Dot se change hona chahiye na. So, how to handle the wire? This is what I have been trying to learn all these years, and I think still I'm not perfect, and the Japanese are very perfect in it. But I think this is very important, and unless you understand how to handle these wires, it's very easy to say you just rotate it and it will go. So the basic principle or the physics of CTO wire tracking, there are three forces you must understand. There is a wire tip force, there is resistance in the lesion, in the loose tissue of the lesion, and there is resistance in the plaque, that is the thing that you don't want to penetrate. So what you want, that is the wire tip force, should be more than the resistance but less than the resistance of the plaque. If that is so, the wire will go the right way. And the guiding catheter backup force adds to the wire penetration force. And if during wire advancement you see that the guiding catheter is backing out, it suggests that the wire is either too weak or compared to the resistance in the lesion, so it's not moving forward, so the extra length of wire that you're trying to push is pushing the guiding catheter back, or it is heading in the wrong way, again it is getting more resistance. So this is very important, one must understand this. The wire has to be shaped, you said it is 1 millimeter, and 1 millimeter shaping is not easy, I can tell you. So please make sure the tip of the wire is only 1 millimeter. You might make a secondary curve. I asked that question to Dr. Asakura also. There are special wires which secondary curves cannot be done. This is the old picture which was used to be done for wires like Conquest, where you do a secondary curve, you can direct it slightly in some direction. So that is that. And the tip of the wire has to be little free from the microcatheter tip. If it is too close, you will make even a simple workhorse wire into a penetrating needle. So please understand that. Second, now this is real life shapes that I have made for you, and this is only 1 millimeter. See the Gaia shape which is there pre-existing, and the XT and the pilots that have been done. So one has to see that. Well, there are factors deciding the choice of wires, which includes like duration of occlusion, whether it's a MI case, pilot wire might be better, micro channels if they are there, and lots of cases have micro channels and which will track with XT as shown by Dr. Asakura also. XT or wizard wire. If the CTO segment straight or bendy, that makes a difference, whether proximal cap is tapered or blunt, tortuosity is there in the CTO segment, calcification and things like that. So, well, this is a chart that I have made. Well, it's difficult to go to the details of it. So, post-MI case, yes, pilot is a good choice, but no, if there is no MI, then I don't think pilot is. It's just by hydrophilicity and a little more penetration force it tries to cross. If regular CTO, it will be a bad choice. If there's a taper present, then XT, XTA, Gaia 1 may be good, but if there is a blunt occlusion, then you need to penetrate. And for that penetration, you need a wire like Gaia 2, 3, or Conquest, and you have to make an appropriate bend. And that appropriate bend you can do on a Conquest, but Gaia probably don't do a secondary bend. The CTO segment, if it is straight, then well, any wire is okay, but if it is bendy, then don't use Conquest. Conquest, you cannot sort of handle, you cannot maneuver it well. And then if there's a branch point, then again Gaia is better because you can redirect it. I will just show some things and things like that. And if you need to access a side branch, CTO stump, I think we are just talking, then make an appropriate bend. You may have a wire on the side, and with that appropriate bend, Conquest is one. Gaia, as I have said, is plus minus because I am not interested in making a secondary curve in Gaia. It cannot stand a secondary curve. So it will only have the tiny curve which will lead it through the lesion, but once you have to angle towards the side branch, you may not be able to do it. That's not the right thing. And no XT cannot stand any direction. XTR has some direction, but provided you can maneuver it in that. Now, you always think softer is always safe. That's not correct. A softer wire, as you see in this picture, can get deflected by a calcium which is sitting here, and that calcium will deflect the wire into subintima, while a stiffer wire will penetrate the calcium and go down straight. So it is not that softer is always easier. I don't know this damn thing is, okay. My choice usually first is XT, second is Gaia 2, third is Gaia 3, and Conquest. The other thing is, which I wanted to show, once you have penetrated, then several times you have to step down, and that is, you advance the microcatheter to the level that you penetrated, and then you step down and use a softer wire, and that's a very standard technique. I think I will not have much time to go into the details of this. I will show you the basic manipulation trick. There are basically two tricks. One is control drill and another is directional penetration. Control drill is for lesions and wires where you are not directing it, and the wire, you are just rotating, and the wire will find its way depending on its relation of the resistance in the lesion and the stiffness of the wire. You rotate it, and for this, wires like XT, XTA, XTR are very nice. And penetration, where you have active wire advancement with directional deflection and torque control, where you use the Gaia wire and you get in. And sliding is another thing for a hydrophilic wire like a pilot, which goes through thrombotic lesions of MIs well. Now, softer tip guide wires like the XT, XTR, XTA have more deflection occurs within the lesion because its tip is flexible, but you cannot make a direction. So what happens is it often gets deflected like this and will continue to remain intralumen only as long as the force applied is not more than the resistance in the lesion. If you apply more force, it will get subintimal. A stiffer wire like Conquest is, it has more penetration power, but you cannot direct it well. So it will sometimes go the wrong way. So straighter segment, it is okay, but if there's a bend, will stay intraplaque only in non-bendy arterial segments, provided you keep it there. Gaia wire is one wire which has good penetration efficiency because of its tapered tip in Act 1, and it has a good deflection control. So you can deflect it because it has 1:1 torque control, the tip shape maintains itself, and so with deflection and rotation, as you see here, you can, and biplane imaging if you have, you can really direct it where you want it to go, and you can literally guide the wire, provided you know where you want to go. That is most important. You have to know the anatomy. So strongest limitation with Gaia wire is, you see, if you see this picture, the Gaias are falling low, so their penetration efficiency is strong, but their tip loads are less. So they enter because of efficiency, they enter a zone, but they cannot exit because their tip load is less. So they will enter a calcified plaque like this, but now they cannot exit, and now you start rotating it, and it will get trapped there. And when it gets trapped, you rotate it more, it will break, and the core wire breaks, and the coil which is there at the top, it is a single wire coil, although it's a rope coil, but a single wire coil, that comes out unrotated, long length. So tips to Gaia wire manipulation, never over-rotate. Always, what I do is advance 2 millimeters and withdraw 0.5 millimeter so that I am sure that I am not trapped somewhere. Redirect and advance. Redirect, direct deflection, and redirect. Do not make a secondary bend. Okay? So now you see this picture, you see the rotation without secondary bend, you can, so the tip is only 1 millimeter, you will be able to manipulate inside the CTO. But if you make a secondary bend, as you see on the right side of the picture, it is literally hovering around because it has 1:1 torque control, it will hover around the entire artery and pierce the whole artery. So you cannot do that. I think this is the Gaia next. I think we don't have it, but This is trying to, because with the multiple coils, it's taking care of some of the trapping part of which was there with the Gaia. So it preserves the Gaia concept, enhances the availability to avoid being trapped, and avoid coil stretching when fractured. And, but this is not available, unfortunately. And then last thing I want to tell you, if there's successful entry in a side branch instead of the main vessel, do not try to redirect these, because you have entered into a side branch, so you are intralumen. You will lose that access also if you try to redirect. I would rather balloon dilate towards the side branch, and the main vessel, for all you know, may open if the lesion is through. And if it doesn't, then I can use a crusade catheter and then go in. That's the picture that is showing that, what I was saying. And at last, I can just, as the time permits, I will show you a couple of examples. This is a RCA occlusion seen in biplane. That's the dotted segment showing the length of occlusion. And always, as I tell you, nearly 70 to 80% CTOs, even if they're old, they have microchannels. And XTR or XT is a good choice, a very good choice that I always strive first. And a lot of it can be done with that, provided you can handle it well. So that is where you are working on it. And you see, actually, oops, damn thing is. So you see it's how the gaps between my two fingers is so small that I am not trying to push it. I am only rotating, and it will go through. Means it will try to go through. So that's the catch in the XT handling. And once I am advanced, then you see I have a gap. So rotation, and now the gap between the torquer and my second hand's fingers, that is the part that will go in. Well, looks simple. I thought it's pretty basic, but I don't know. But I think these things are very important. Being a CTO course A to Z, I thought I will show that. And that's the final. One more case. You can tell me if the time is over. I will stop there. This is a circumflex ISR, and if you see that the wire has got subintimal, and in these situations, we used to do parallel wires, but Gaia is a good choice. You can redirect it, and here in this case, I changed it to Gaia 2 or something. Gaia, the Sion got subintimal, and you see that's the, I don't know what's the rotation is. So here it is only like pecking on the wire. There is no pushing at all when the guy is only pecking very slow and trying to give a direction, and I'm redirecting it. And then once I've got the feel that it is through, then I have, of course, advanced it. And you see the check picture, and then you see you are in. So it can be used to redirect also. I think
the time is over.
Yeah, I think I will stop it here. I'll go to the last. Can you show me the conclusion slide, please? Can I see the conclusion slide, please? The last one. So to conclude, friends, understanding different CTO wires and each higher wire handling techniques are the key to successful crossing of a CTO lesion. Gaia wire is totally different from any other CTO wire and can literally be driven to where you want it to go, provided you know where to go. Thank you.
I think due to lack of time and the pressure is coming from the person sitting there. And thank you, Dr. Goel, for the wonderful presentation. And we'll go for the next talk.
Thank you.